Now let's talk about how to manage cervical intraepithelial neoplasia. So first, CIN. What does CIN mean? So CIN is the biopsy finding you see after a colposcopy. So anytime you see CIN 1, 2, or 3, these are findings that are determined based on a biopsy of the lesion in the cervix. And it's a pre-malignant cervical condition. It's not malignant yet. It's not considered an invasive cancer. It's a pre-cancer. So the ectocervix is made of squamous epithelium and results in squamous cell cancer if it becomes cancerous. So that's why CIN refers only to squamous cell abnormalities, not to endocervical or adenocarcinoma abnormalities. On the other hand, the endocervix is made of glandular epithelium, and that leads to adenocarcinoma. So what we care about CIN is talking about squamous cell carcinoma only. Okay, key thing to keep in mind. CIN1 management. What are we going to do with CIN1 here? Women 25 and older preceded by a low-grade PAP. What are we going to do with these patients? So they had an ascus or LSIL and eventually got a biopsy and found to have CIN1. What happens in these women? You do HPV cytology co-testing in a year. So remember, CIN1 is not too concerning. It's not a big deal. So you don't need to worry too much. We just have to check them up in a year with HPV and cytology co-testing to make sure it hasn't gotten worse and to make sure it's gone away. So after a low-grade PAP, when you get a colposcopy and find CIN1, you do HPV cytology co-testing in 12 months. If it's normal, go back to regular screening. But if any abnormal results or HPV positive, you need to repeat the colposcopy and biopsy to see if the CIN has stayed the same or become worse. If you have CIN1 for at least 2 years, so say this initial CIN1 after the colposcopy and biopsy after 2 years stays the same, it needs an excision. And it's called the loop electrosurgical excision procedure, where you excise the damaged or lesioned area off of the cervix. But this does have complications that we'll get into later. If you have CIN2 or 3, we'll talk about that in the high-grade lesions section of our presentation. Now, what about women 25 and older preceded by a high-grade PAP? So the previous was a low-grade PAP. Now what about a high-grade PAP? And that's going to include atypical glandular cells. Okay? High-grade PAP means ASK-H, HSIL, or atypical glandular cells, like we mentioned previously. What we're going to do now is we're going to do HPV and cytology co-testing at 12 and 24 months. You're probably wondering, this is a high-grade PAP. Why aren't we doing something more? Because we already know it's CIN1 from the colposcopy. This is not too serious. So we're going to keep checking them up to make sure everything is okay. So you're going to co-test at 12 and 24 months. If they have any HPV positive or cytologic abnormality except HSIL, you need to repeat colposcopy and biopsy and figure out what's going on. If it's HSIL, however, you go straight to the loop electrosurgical procedure. So if they have another test that says HSIL, you want to get rid of it because there's some high-grade squamous intraepithelial lesion things going on here. And you want to be safe and get rid of it before it becomes invasive cancer. So now let's talk about the tables again. We always want to go through the tables to understand what's going on and to have an easy way of remembering what happens in these different flowcharts. So let's start with CIN1. So first we talked about CIN1 in women 25 plus, preceded by ascus or LSIL, a low-grade PAP. You have HPV cytology co-testing in a year, like we mentioned. And if it's HPV positive or greater than or equal to ascus, you do colposcopy and biopsy. If it's CIN1, you do HPV and co-PAP co-testing again in a year. If it's CIN2 or 3, you go straight to LEAP. All right, LEAP being you cut out the lesion. Now, if you have negative testing on this HPV cytology, both the HPV and the cytology are both negative, you can go back to routine screening. Now, what about women who are 25 plus preceded by a high-grade lesion? We're going to do the co-testing at 12 and 24 months in this case. So HPV positive or greater than or equal to ascus, like we said, colposcopy and biopsy again. So if you have either of these being positive or greater than or equal to ascus, but not including HSIL, you go to colposcopy and biopsy. CIN1, do retesting in a year. CIN2 or 3, go to LEAP. Okay? HSIL, we mentioned, if you have HSIL again, this means that there's some kind of high-grade lesion going on here that you want to be careful about. So you want to cut out that area because it could be cancerous. So you do a LEAP. And if it's negative at both 12 and 24 months, both the HPV and the cytology, you go back to routine screening. So know these charts. They're very helpful, very easy to go through if you go through the charts. I know the reading in the previous section can be kind of confusing, but here they'll be a lot more understandable and doable. Now let's continue with our CIN management. So CIN1, how are we going to manage it for other age groups? What if the women are 21 to 24 years old with a low-grade PAP? So I know we have so many different age groups going on here, but we want to think about what happens in all these situations because you could be tested on it. Repeat the cytology in 12 months. So you don't do a HPV test here. Remember, in women 21 to 24, you don't really do HPV testing because of the high rate of HPV in this population. If it's negative, ASCUS or LSIL, repeat in 12 months. And once again, if it's negative again, you go to routine screening. But if it's greater than or equal to ASCUS, you go to colposcopy. So after the repeat cytology, if it's a low grade or negative, you repeat it. If it's anything greater than ASCUS on the repeat, you have to do a colposcopy. And if it's ASC-H or HSIL, you go straight to colposcopy because of the high risk of a severe lesion. And remember, these colposcopies are also going to come with biopsies if there's something of note or a major lesion that needs to be examined further. Now, what about women 21 to 24 with a high-grade PAP? Remember, high-grade PAP means HSIL, ASC-H, and atypical glandular cells. What are we going to do in this situation? We're going to observe every 6 months this time with cytology and colposcopy. So you're going to look it up every 6 months to be careful. Remember, this is CIN1. We're not too concerned, but we want to make sure it doesn't get worse. So we do cytology and colposcopy. If you have 2 negative cytology results and no high-grade colposcopic abnormality, go back to routine screening. So if the colposcopy doesn't show anything too serious and there's negative cytology results, routine screening is back to normal. However, though, if you have HSIL and cytology at any point, or if you have a high-grade colposcopic lesion, you need to repeat the biopsy. And if the biopsy shows something abnormal, you need to go to LEAP. And if you have anything else, you're going to go back to colposcopy and biopsy as well. So you have the negatives, you have the in-between where you go to biopsy and colposcopy again. And if you have the HSIL and cytology or a high-grade colposcopic lesion, you biopsy it, and if it shows something major, you have to do an immediate LEAP procedure. So now it's CIN 2 or 3. So if you have a CIN 2 or 3 with adequate colposcopy, you're going to go straight to a LEAP. Remember, an adequate colposcopy means that the transition zone of the squamo-columnar junction of the cervix is sampled and the lesion is fully sampled. If that shows CIN 2 or 3, you have to go to LEAP because of the risk of progression of this cancer. If there's an inadequate colposcopy and a high-grade lesion, you cannot rule out cervical cancer, and another LEAP procedure is needed as well. So if it's inadequate, meaning the lesion was not properly identified, or you didn't get a good idea of what the transition zone looks like and a good sample to rule out cancer in the transition zone, you have to do a LEAP procedure. So what are some complications of LEAP? Remember, this is an electrosurgical excision procedure. So you can get some cervical incompetence, you can get preterm labor, you can get problems like that. So important things to know. What are some exceptions to this regular CIN 2 and 3 management? Pregnant women are definitely an exception, and so are young women who plan to have children. So we will talk about these in an upcoming slide.